You've waited all week.
Every week, we continue to learn how to achieve a better back and ultimately better health.
Live in the WIKB studios, this is Dr. Larry.
Well, thank you for hitting the plus capacitor read. Hello again, everybody. Okay, let's get it started. Well, as you know, every show builds on the next. Every week, we continue to learn how to achieve a better back and ultimately better health. Now, in case any of you missed it, last week we talked to a rheumatologist. It was an important week to be tuned in because we learned and defined about what a rheumatologist is and can do for you, because let's face it, you may need them when your joints are feeling blue. So here's a short clip for you to listen to from last week.
Give us one unique personal talent or hobby or interest you had, if you play an instrument or something that you like to do maybe in your spare time that we will all like to maybe hear or know about.
Oh, I'm not talented at all, I say. So I don't cook, but I think I make very good butter chicken if anybody wants to try it, which I don't know if many people know what that is, but it's like chicken with a lot of butter and sauce and gravy. I think the only talent that I can think of that I really have is I am a very fast reader. I read my books from top to bottom rather than left to right, which is slowing down with age, but I think I'm still pretty proud of myself on how much I can read in a given time.
So wait a second.
And as far as
I'm sorry. So you take and you can look at a book and go straight down from top to bottom instead of the typical way, left to right?
Yeah, and that's what I tend to do. Like I wouldn't say that I'm like very fast at doing that, but that's how I read, top to bottom.
Was that something that you developed as you were going through school, or did you always have it since you were little?
I don't know. I think that I realized during residency when other people said they couldn't finish the exam, and I was like, what are you talking about? Like, why do I always come out of the exam finishing it like 2 hours or 3 hours earlier? I never had problem finishing. Like, everybody would say that was a long stem of the question, and I'm like, what do you mean?
Yeah.
And then I realized that I think I read differently. I never even knew that I did it.
Yeah, so there it goes. It was kind of just innate and natural for you as well, too. Was that one of those things, too, even when you're so if you're reading through medical records and you got a stack in front of you or flipping through the computer, do you find it's the same thing, like you're going through somebody's case history?
Yeah.
Do things just kind of jump out at you in a more of a column format versus left and right?
Yes, I would say that because I know that a couple of patients, sometimes they bring like symptom list or something written, and then I would scan, and sometimes they would be like, I can see it on their face that they're like, did I read it? Because that's how I scan. And then I would ask the question that was written, let's say on the 8th line, and they were like, oh, you noticed. I'm like, yeah, I am just a fast reader. I paid attention.
Which I'll tell you, because I've done some shows, I do a mixture of different types of shows. I'll talk about, case specific, bringing on medical professionals, but I'll talk about just kind of healthcare stuff, specifically from the standpoint of information, retention, doctors going through studies out there about when you go see a physician, when they're reading your stuff, how much are they retaining, how much are they able to put down when you're giving them information. Is that information accurate? I've gone through all that stuff in several shows before. And one of the things that kind of bubbles to the surface right now is the fact that it's absolutely key that as you're working through your day and everybody that comes to see you, that's their visit with you, even though you may have a full docket and patients coming, everybody, this is their time, their moment. And to the extent that you can be able to decipher the important information and then also retain it in a way as if you had been reading it for hours is really kind of a unique skill in and of itself with the pace of things go as it goes nowadays and be able to figure out problems. So I'll call that a personal unique talent. So, okay, what I'd like to do is I'd like you to briefly describe and discuss what a rheumatologist does. And also, too, as you're thinking and answering this question, maybe 3 or 4 common reasons why a patient would see a rheumatologist. But first, just kind of give us an overview of a rheumatologist.
So I think that you probably, explained it very well, that yes, it all starts with arthritis because that's what, most people know about rheumatology or joint diseases. But when it comes to rheumatology, as I would like to say, that there is not just one kind of arthritis. There are like tens of hundreds of arthritis that can happen from different conditions. And that can be just one part of their whole disease or their whole self. Because many of the diseases that we see in rheumatology that can affect them systemically, meaning in different organs, like the same thing can affect their lungs, brain, heart, kidneys. So it's, and I think that's why probably I enjoy it more, because it's the whole patient. It's not just one specific area. But yes, inflammatory arthritis or arthritis related to inflammation that causes swelling and stiffness in the joints is something that brings attention, to the patient, or even for the patient brings attention to their disease, that something is going on with them.
Would you? So then, in a way, it's almost like you're a bit of like internal medicine, a bit of almost what a primary care would do, but with a hyper focus on the inflammatory component of the joints.
I would agree with that statement. That yes, and that is why there is internal medicine training that goes in before rheumatology subspecialty training, and I do think that going through that, with the full 3 years of internal medicine training, actually helps prepare for rheumatology. You're absolutely right. That yes, it's more honed in, it's more specialized, but we have to know many things about different organ systems, different medications, because of the medications that we prescribe sometimes can have interactions as well.
So as far as the 3, maybe to 4 common reasons that a patient would want to see or make an appointment with a rheumatologist, what would those be?
So that was some of the highlights and the focus of our 1 hour entire show last week. However, if you missed the show and want to be more in the know, then log on to my website, drlarryradio.com, hit the sponsor button, follow the links to become an official sponsor of the show today. That's been uploaded now, which you can listen to the entire thing at your leisure. And here's the final point. If your joints are inflamed and in pain, just remember, Dr. Sethi and rheumatologists are in the game. Now, beyond that, in addition to the chit-chat, last week we learned a simple self-help for a frozen shoulder. It was another Dr. Larry cool tool. You can call my office for a freebie reminder just in case you're in need of a retip or a tip up. And so that was last week. Hi-ya! Now today we'll forget that monologue for a moment and keep remembering those mandatory communication skills all doctors must have, which are inquisitive listening and staying positive. Again, it often means the difference between sick and well. Also, it's another month of the year, so let's keep our deltoids in gear. Yes, deltoids. I will explain why, because this fools and is often mistaken for rotator cuff tears, but it's not. So hang on till the end of the show, though. That's in our tip and trick segment today. We're going to learn a simple self-test for deltoid tendinitis. And of course, you, Rito Dorito, are calling it out right from the broadcast booth while we crank up the tunes and I hit the center stage for the demo. However, before all that, in order to have good health, you don't need a lot of wealth. So let's flex our forebrain and put some knowledge of the game, because today we're going to talk about, hit it, Pearl.
Dr. Larry brings you another segment of Did You Know?
Arthritis. A long time ago, arthritis got its name and claim to fame. And now we know arthritis is as famous as Johnny Unitas used to be. But it is wanted or needed as getting stung by a bumblebee. Because we've all heard somebody say, "Oh, I hurt with arthritis." In addition, commonly in healthcare, there's a lot of chit-chat about arthur, what causes it, why it gives us such a fit, and the ultimate question is, when will it ever quit? Because it causes big problems in the function of our hips, knees, spines, and more. It's a type of condition that if in your later years, it can make you shout and let it all out. And maybe that's what Tears for Fears was singing about, because arthritis we can definitely do without. So come on, all you arthritis sufferers, I'm talking to you. Come on. I have some information to stew. Reed was, you were bebopping over there. So if you have arthritis, then pay close attention to our guest. She, as you heard, is a practicing physician, board certified in a field that deals with this It's a show you will not want to miss because I'm bringing you part 2 with our specialist. Our interview with Dr. Sethi, we're talking about today infusion therapy for different types of arthritis. Roll it. Let's roll through 3 conditions where you have a condition and the infusion treatment was medication, and then this is what the medication intended to do. So really what it is, it's kind of a little mini sort of series here and a little mini class on the condition, the medication, and the effect on the body.
So rheumatoid arthritis being like relatively more common than other arthritis, I'm going to start with that. And just like I said before, that different chemicals are involved or cytokines are involved in different patients when it's causing the disease. So some of the biologics that we use, or I'm going to say like the first one that came out specifically for rheumatoid arthritis was infliximab back in 1990. Now, biochemically speaking, it is what we call an anti-TNF, which is tumor necrosis factor. But basically what that chemical does in the body is that it can cause inflammation at a certain level and destroy some of the components of our own system if it is too much in the body. We all have some, and it's just basically a balance in the body, but when the balance is off is when we try to reset it or to try to modify it by giving other medications. So when the infliximab came out, the effect of that medication was that since it is stopping the inflammation, basically people felt better from within, and it was able to help control many facets of the disease and not just joint disease. We also saw that when the disease was better controlled, the heart disease was also better controlled in patients with rheumatoid arthritis. And there are like many, because one was developed and it was successful, it showed to be better than methotrexate alone. Many other companies made different molecules of the same kind. So we have like 5 classes of drugs 5 different drugs in the same class of medication.
Makes sense. So
the side effects.
Oh, sorry. Yeah. So methotrexate, of course, is I would say pretty well known, but then underneath that there are 5 subclasses or in the same family of medications, and then the effect is control or suppress the inflammation. And I think you named, if I heard it correctly, was it like a inflammatory protein that it basically suppresses, like bradykinin, cystokinin, those kind of things? Okay. And so the effect then is once you have the inflammation suppressed through the infusion treatment, you said you noticed that it affects other areas of the body in a very positive clinical outcome as well. In what way?
Yes. So the idea is that when people with rheumatoid arthritis or any inflammatory disease, when there is uncontrolled inflammation in the body, it has other effects on the body as well. So many people may have like a fatty liver disease, for example. They get higher incidence of heart attack and stroke because of that ongoing inflammation in the body. And what we saw as people were being treated, and it's more about the control of the disease. So whenever we find any drug that controls the disease better, we see the whole person or the whole body getting better for the most part. So when methotrexate came on, we also found that methotrexate actually had the tendency to reduce heart disease risk as well. And the same way we saw that in many anti-TNFs where the heart attack risk went down as we treated the medication. But at the same time, I also want to make sure that people also know that not every medication is for everybody. And these medications also have their side effects. So because they were working on the immune system, there was more risk of infections when we started using these drugs. So we do try to check for TB, hepatitis, and things like that. Before we start the patient on this medication, we do want to know what their other medical history is so that we don't, aggravate any other situation by doing this.
Excellent. And like we talked to, is there's always going to be 1 or 2 great nuggets or walkaway or takeaway points that as people are listening to explain that. So properly treated RA with one of the 5 to 6 medications that you've mentioned, controlling the inflammation can reduce, and with the assumption too that there are not going to be any opportunistic infections or issues or problems. But let's say that those are nullified. We're okay there. It can reduce the incident or onset of heart attack or cardiovascular style diseases or processes by controlling that inflammation through the RA. That is very interesting, and I didn't know that those two were to be necessarily related. So, folks, when you're listening to Dr. Sethi talk about this too, if you do have potentially RA or in the process of getting this diagnosed, keep that in mind as well too for overall heart health and reducing the incidence. So, very interesting. How about another condition that would be treated with infusion therapy or infusion treatment, and what type of medication? What would be a second condition?
So, just like with the rheumatoid arthritis, we got these medications. We found out that people with psoriatic arthritis or psoriasis, they were also very responsive to similar medications that we ended up using for rheumatoid arthritis, but not to all of them. Because again, the disease was different. It was causing inflammation, but it was different. It was going to the skin more. While rheumatoid had the tendency to probably, if it was going to affect another organ, it would be, for example, the lung. And in patients with psoriasis, methotrexate was effective, but not to as good of a degree as it was in rheumatoid arthritis. So we have used similar medications, like I just said, in psoriatic arthritis, but there are additional medications like Cosentyx or axetuzumab, which is the trade name right now is Taltz. I don't think there are biosimilars there yet, but there are many different medications in those classes, which we call IL-17. But basically what it is it's a different kind of molecule or chemical that causes inflammation in different areas of the body. And this time it can go into the tendons, into the spine, which typically the rheumatoid will not go.
Got it.
So similarly, go ahead, please.
Yep. So, okay. So again, we're still in the main thread of inflammation, but with a different style of arthritis, psoriatic in this case. In order to be the gatekeeper, in order to have the key, the molecules have to be tweaked just a bit in order to be able to have the same therapeutic benefit, where methotrexate kind of fell off the cliff there a little bit for psoriatic. Real quick, what would be a sign or symptom, just generally speaking, of psoriatic arthritis? What would a patient present like? Just maybe give us a minute or two on that. So hang tight. If you think you may have psoriatic arthritis, that question is going to be answered just after the break. Plus, we're going to dive into some more infusion therapy discussion, the medication, and how it affects inside your body. Also, keep in mind, too, pick up little nuggets of points. Think about the things that land on your ears that you hear. Inflammation, you hear that repeated. Inflammation, how it translates into negative effects of other body organs, your heart, your lungs, etc. So Dr. Sethi is going to be giving us some additional perspective on that. Just around the corner, you're listening to the Dr. Larry Radio Show. We'll be right back.
Dr. Larry will be back in a moment. Break's over. Time to get cracking once again with Dr. Larry.
Welcome back. If you're just tuning in, on the show is Dr. Sethi, rheumatologist with OSMS. We are going over arthritic conditions, infusion therapy, and eventually some successful cases. Roll it. What would be a sign or symptom, just generally speaking, of psoriatic arthritis? What would a patient present like? Just maybe give us a minute or two on that.
So for psoriatic arthritis, most of the people, I would say, they probably also have psoriasis somewhere. And the interesting point with psoriasis is that, of course, it is the red flaky skin that people get. And it's fairly common, I would say, and it's easy to see when it's there on the knees and the elbows. But some of the patients actually have psoriasis that in the hidden spots. And sometimes we end up seeing the patient because of joint pain, and only because we were trying to look for, because it fit the pattern of psoriatic arthritis, that we find that, there was psoriasis, but this time the psoriasis was in the belly button only, or on the scalp only, or I have seen recently a case in the gluteal cleft area, where the psoriasis was hiding. But the difference is that in patients with psoriatic arthritis, they have some involvement of the back, which rheumatoid arthritis patients don't get. They still get swollen joints, but typically their swollen joints are more asymmetrical. So they may have it in the hand, but have it on the left knee instead of it going to all the joints, which is what typically rheumatoid arthritis would do.
Okay. And folks, as you listen to Dr. Sethi go through this, there's a term in medicine or in healthcare called differential diagnosis. So that's kind of why I asked her that question, because there is a difference, and again, even heard from effectiveness of treatment, you got to have the correct diagnosis between RA, psoriatic, and then I'm going to tie into the third condition of infusion, a third common condition you would treat with infusion therapy. What would that be?
So other than these, we do use medications, for example, for myositis. Now, myositis is not very common, but the treatment that we use for myositis sometimes overlaps with vasculitis, which many people may be familiar with, which is blood vessel inflammation. So sometimes we use medications like rituximab, which was originally used for lymphoma, but then found its use in rheumatoid arthritis in different dosages, or blood vessel inflammation, which is vasculitis, in different dosages. And that's a different set of, chemical again. So it's not one specific IL-17, IL-23, or IL-12. It's more B-cell depletion, so it has more broad-based use. And that is why it's used in lymphoma, because it's trying to suppress the B-cells.
Got it. What is a clinical or patient presentation with myositis? What do they look like, or what are their symptoms, or how to describe?
So classic presentation of myositis by the book, I would say what we learned, like in med school, for example, we say it's muscle weakness without pain, usually. But although in real patients, I would say some people will also say they have pain, but pain is the lesser of their symptoms. It's the weakness, and typically what would happen is that this person is active otherwise, and there is no injury, there is no neck pain or like back pain, for example, that is causing leg weakness. And they start feeling that very gradually it's very difficult for them to lift their arm up. And typically it goes both arms. So it would be that I can't comb my hair, or I cannot raise my arms up, or like I cannot go up the stairs because my legs are weak. But they hardly, they won't start with, oh, I'm in so much pain, I can't do it. They will say, I can't do it.
Now, would that be something where, in a case like this, the neuro is intact, right? We're not having any abnormal studies on EMGs?
No, so the EMG will be abnormal in that case, because the EMG will check for any muscle fibrillation and potential. And in this case, the muscles are inflamed. So when the neurologist would do an EMG, they will be able to figure out that this was a myopathic pattern or a muscle disease pattern, which was causing the weakness.
Now,
we do utilize EMG to identify this.
Okay, and would you be picking up on any enzymes dumping in the blood, like creatine, anything like that, with this kind of condition? Muscle weight?
Yes. So the blood test is again, first of all, it would be the exam, and when the exam is consistent with it, we do blood tests first for seeing, is this even correct? So for me, I want to confirm, hey, I'm thinking it's muscle disease. Let me check muscle enzymes. If the muscle was inflamed, it will spill over the enzyme that is strictly limited to the muscle. And there are like 5 enzymes that we can check for that. And we would check that because we don't want to miss on it. We will check for all 5. And if it does seem that this makes sense, those were elevated, there are some autoimmune markers that can help identify that if it is a muscle disease, what caused the muscle disease. So myositis is still just one term, but there is polymyositis, dermatomyositis, and then there are specific antibodies or blood tests that can identify what caused it in the first place and how aggressive could be this muscle disease, because some of those are better amenable to treatment, if I may say that. Some of those can cause skin disease, some of those can cause lung disease. So we need to know what we are dealing with. And some of those can actually be seen in people who may, have cancer going along with it, which thankfully is not very common, but we do see some in our patients with myositis. So some of those blood tests are able to identify on who would be at more risk and whom should we do more screening in for everything.
Got it. Yeah, and listening to you explain this too, and I hear these overtones. I've got internal medicine doc that I've known fairly well for quite a while, and his famous quote to me is, Dr. Lair, what I love about being in internal medicine is investigation. I like to problem solve, figure things out. That's kind of what internal medicine does. And listening to you at the first time really speaking in kind of a Q&A format with you as a rheumatologist, there's a lot of tie-in to different body systems and other, as this pulls into different disease processes, other organs and related tissues. So again, myositis is not something that necessarily is talked about at the coffee table as somebody having, but that's why I asked you about patient presentation. Is the medical sort of knee jerk is muscle weakness without nerve deficit or any other issue going on. Then from there, of course, it involves the exam and some labs as well too, which brings me into kind of the final segment of the show here too, and is getting into successful patient cases. And even with infusion treatment, I'd like to go through 3 cases where a patient came in, presentation of symptoms, this is their diagnosis, and then you treated them, and this is what was the outcome. I'd like you to roll through 3 of those cases for us, just so we can kind of hear this play out in real life. We like home runs as human beings. We like when we go to the doctor and we get fixed. And so if you go through 3 cases for us, would be wonderful.
Okay. So I'm gonna start or preface this by saying that as I was trained in when I did my fellowship in rheumatology, and I had a great program. I learned a lot from the mentors that I had, and there was a lot of focus on using methotrexate and conventional oral medications. And I am a true believer of you start low and then you build up. And but what I'm trying to say is even though we are talking more about biologics, those medications do have a role, and I always use them first. But there have been some dramatic things that I have seen with many medications, including methotrexate. But since our focus is we are talking about biologics here and trying to see what those do to our body, there is one case that it probably will always be fresh in my memory. And probably not everybody gets lucky like this case, but it happened one time. I had 2-3 years ago, I was in a different system. I saw a lady who had long-standing psoriatic arthritis. She was on methotrexate for 10 years. From what I could tell, because she had previously seen another rheumatologist and then probably was not seeing anybody for some time in between, is that she always had some joint inflammation, but she thought that this is the best that she could do, and she was content with it. When I saw her, it was because she started to have severe pain in her right foot and couldn't walk, and she went to urgent care, primary care. They tried to help her. They gave her anti-inflammatories. They gave her high doses of steroids, and nothing is working, or working but not really, 20% benefit or something like that. So when she came to me and we talked about treatment options, and I said, well, you're on full dose of methotrexate. You already did steroids. You did anti-inflammatories. Let's just go for a biologic now. This would be the right time. And at first, she was somewhat reluctant. It was, of course, a new thing for her. And then she gave in. In her case, we used an infusion. That is what the insurance paid for. And she was nervous about this, and she called me on the day of her infusion from the hospital that she was getting the infusion in. And my initial reaction was, oh, she probably had a reaction. And then my nurse gave the phone to me, and my patient told me the medication is working. And I was like, well, you are just getting the infusion, right? And she's like, yeah, but I can tell that it is working. And I took that, of course, with a grain of salt. How likely is it? I just gave the medication. Except that her follow-up appointment was 2 days later, and she was right. Her foot was 50% better by then already.
Almost instant. So, as the medication was being administered.
Yeah, and I mean, as I said, I didn't believe it at first,
Sure.
Because I was like, that can't be. But she was right. And after that, I have heard, again, every patient is different. I don't want to make it sound like I'm selling goals. It's not every patient will go through this. That is why I remember this case, because not everybody goes through something like this. But yes, after her, I have also seen some other patients who described that when it's the right medication at the right time, like for that particular person, sometimes the change can be as dramatic as that.
Yeah.
Although in general, I do tell people it takes 3 months to work. Like I never use these words that it will be instantaneous.
You know, and I think, Tom, sometimes, too, what it's nice about going through patient cases and successful ones, and it's a good lead-off case, because what happens is it's nice to hear, basically, as we're leading up into this successful patient cases with fill-in-the-blank therapy, that we like to hear when everything hits just right. The patient's own biochemical, I'll just say, internal processes were ripe and ready to go for the medication. The dose was specific and on purpose, and everything just kind of lined up how it should. It was instant. And what it does is it really makes the case and the argument for the fact that, by and large, most people are not going to respond that quick. But in a sense, if you just wait on it and hang out, and based on the studies, it may take, like you said, up to 3 months. A case like this proves the point that although not everybody's going to be that quick, if you do the therapy and go through the entire treatment, by the end of it, you'll have that improvement that is, you know, close to similar, or at least better than what you were than before you started. So, you know, those cases are fun. They're yes, like you said, not maybe the norm, but hey, and I like the fact that the patient actually knew it and felt it, and to the extent too, I was listening to you talk about it. I'm a natural born skeptic. People just kind of know that. I question everything. I'm always asking questions. You know, I don't assume anything. So I'm just that person, my wife says. And so as I was listening to you, I was like, yeah, but let's wait and see. Prove all things, measure twice, cut once. So it's nice that you know, but you still got to keep an open mind that, hey, by the way, and this is kind of my always fallback is patients. I always tell my patients, who you live with this 24/7. I don't. I'm seeing you for a fraction period of time. So tell me what you feel, what's going on. And that's kind of what you did with this case. And by the way, too, if you've got, like you said, and I'm glad you qualified that, because I was very specific on the show today, too. I wanted to go through what you did and through some basic disease processes that you treat. And, of course, the infusion thing, which can be a little bit of a hazy concept, like what is this? But by all means, your statement, the fact that you build up slow, that there are things that you can do without having to go to this route necessarily, is another kind of a tool in your box coming from being a rheumatologist, that it's not always infusion treatments or even necessarily other types of medications. Sometimes it's just a really very basic, you got your eye on this, you figured it out, maybe you tweak a few things and patient's better. And I think that by all means, if you got a case like that to throw in there, but I'd like you to run through 2 more cases of your choice, whatever you want to go through. It can be infusion or not, of success cases, so we can hear. The first one was great. So this is the icing on the cake, and here's a little audio bait. Dr. Sethi is going to touch on hydroxychloroquine, which autoimmune condition it's used for, and it can treat after a short break. Stay in your car. Turn off the washing machine. Hang on. You're listening to the Dr. Larry Radio Show. We'll be right back.
We'll be right back with Dr. Larry. We're back with Dr. Larry.
All right, Dr. Sethi is going to touch on hydroxychloroquine in just a few minutes, which an autoimmune condition it's used for, and it can treat. Roll it. I'd like you to run through 2 more cases of your choice, whatever you want to go through. It can be infusion or not, of success cases, so we can hear. The first one was great.
Since, again, like in my mind, I was thinking that we will talk about biologics, but since if it's open to like any treatment, I'm going to...
You bet, Dr. Sethi. It's my show. I can change the rules at the end.
Okay. So I'm going to talk about a patient who was very dear to me. Unfortunately, he's not with us anymore because he developed ALS. But he... like when I saw him, he was around 69 years of age. And he had some kidney involvement from before, like for the last 3 to 4 years. He used to see nephrology. He was not on dialysis, but something had happened to the kidney. And basically what he had was like a long-standing joint pain for maybe like 10 years or so, but nothing that would be very like bizarre or very swollen that it would look like gout or anything. So more slow, like fatigue, some joint pains, sometimes chest pains off and on. And when I saw him, so he was a patient where I felt like, okay, the history does say something inflammatory, but I'm not sure what is the kidney doing here. And as we did the blood test for him, he had some markers for lupus, but not a very classic case. Like he is a Caucasian male in that age group. Lupus is not as common, although it can happen. But after seeing the markers, and then, again, like the kidney is involved, he said chest pains, things like those were going on. We started him on a generic medication called hydroxychloroquine. And again, I use that because I can never forget on how much difference sometimes the right time, the right treatment can make. And in his case, what happened is that this is a person who cannot take Advil leave because of the kidney involvement and things like that. He takes hydroxychloroquine. 3 months later, he comes in with a pain score of 0. Wow. And feeling extremely well. That once he got better, I asked the nephrologist and said that, have you checked, like, you should probably do a kidney biopsy. Like, I think that the way he is responding, he probably has lupus with such a, like he had some markers already. It wasn't very clear cut, but I think he has it. And he ends up getting a kidney biopsy later that showed a very mild grade lupus involvement in the kidney, which we were able to get better, after the start of the medication, and we were on the right path.
So you basically treated almost like an occult, hidden, but was showing certain variations of symptoms of an autoimmune disorder, lupus, with kind of an oblique medication there, and it worked. It's right. I mean, that's because that's not. Are those two? That medication and lupus, are those two typically joined together as far as a treatment protocol goes, or is that something that you?
Yes, absolutely.
Okay, got it. And I didn't know that. It's
classic. Like I could probably even, that's not probably a scientific thing to say, but I could probably even use the word that it would be a sin to not put the patient on hydroxychloroquine if they have lupus.
Interesting.
Probably like it's not as strong of a statement, but yes, that's how related those two things are. We always do it.
You know what? That's being out in practice. That's seeing patients, like you made the compare contrast medical school and what the patient presents. That's where you really can refine and hone in your skills and start really treating patients and be effective when you're able to take one variable and put a different variable with it and make it a constant. That's perfect. Okay, well that's a home run baseball analogy. Let's go for a third and final case, and then we'll wrap up the show.
So third and final case is like very recent. So there is a condition, blood vessel inflammation vasculitis, a condition called GCA. Basically, in this condition, people can get headaches. Sometimes they have hip and shoulder pain with it. But the main worry with this disease is that this can cause or lead to blindness. So usually in the past, we had no choice but to put people on high doses of steroids for a period of a year or two, or sometimes even longer, because that's the only thing that we knew worked for sure. And over the last few years, there was a medication called Actemra that is or tocilizumab, to keep, not to advertise for any one particular medication, but it got approval for this condition. And in my case, I used this particular medication. And what happened is that this patient of mine, he has had some hip and shoulder pain going on for some time, then developed this classic case of what is GCA. And then we started him on this medication. And this is the first time in the last 3 years that his dose of prednisone is now down to close to 5. And he's going down by 1 milligram every week now. So he's close to 5 because it's current, I'm pretty sure that when I see him next time, he will be on 0 milligram of prednisone.
Excellent. On a high dose prednisone down to almost nothing, and working from a different angle. And as you know, too, I state sometimes too, if people have to be on prednisone or some type of steroid like that, oral medication, and I said it works. It works really good. Long term, you just got to watch out for it. So work with your doc about that. So in this case, you effectively are able to probably eliminate it down to almost zero. Well, that is a grand slam of 3 cases right there. I really appreciate you going through those, and I'm glad you mentioned that too, because I do like to hear how you would approach different cases, not necessarily through infusion treatment. So that kind of dovetailed off into a nice little mini segment there. Dr. Sethi, if listeners want to contact you for an appointment, what is your phone number? And also, if you don't mind, give us the website of OSMS.
So anybody who wants to contact us, like online, is www.osmsgb.com. And our phone number here is 920-430-8113.
Once again, folks, this is rheumatologist Dr. Sethi from OSMS, and thank you for going through everything with us and explaining some of these disease processes and also the clinical aspect and from a practitioner standpoint, how you treat those. And I think out of this segment, there are some great walkaway points that we can all grab from this. And at some point down the road, love to have you back on the show and go over some more different aspects of rheumatology, what you can do. Dr. Sethi, thank you for coming on the show today.